Okay, hello everyone. This is Alex Chan, and I am going to be presenting my pathophysiology presentation for advanced procedures. The topic is diagnosing renal aneurysms via renal angiography. So, what is a renal aneurysm? In short, it is a ballooning of the renal artery that progressively weakens the vessel wall. In serious, severe cases of RAA, renal artery aneurysm, the renal artery may rupture and lead to internal hemorrhaging. So the RAA can be occurring anywhere in the renal artery, but is most common in the main renal artery bifurcation branch as a saccular variety. Most patients are typically asymptomatic and are found incidentally through unrelated imaging exams such as X-rays, ultrasound, or CT. And although RAA is rare, males over the age of 50 with a history of smoking and hypertension are those that are most at risk. So again, RAA is most marked by vessel ballooning within the sizes of 1 to 10 centimeters. And typically RAA is diagnosed via digital subtraction angiography, CT angiography, or magnetic resonance angiography, MRA. These imaging exams are performed to diagnose, localize, and assess the severity of the aneurysm, which is then treated through periodic follow-up, aneurysm resection and artery reconstruction, stent implantation, or embolization of the affected vessel. So there are several types, but let's go ahead and show you what a normal renal artery will look like versus a renal aneurysm. On the left, you can see mid-catheterization, that is what a normal renal artery branch would look like. And on the right, you see those saccular types of the renal artery aneurysm, and that is the most common. So let's move on to different types. Types of renal aneurysm, again, as I mentioned, saccular. Those balloon in one direction and are the most common types of renal aneurysm. They account for approximately 70 to 75% of all cases. Fusiform aneurysms, which balloon in one direction, those account for 20% of the cases. Dissecting aneurysms, which are interparenchymal between the layers of the vascular tissue of the endothelium, the tunica intima, the tunica media, and the tunica externa. And arteriovenous, which are fistula-based between the artery and the vein, and that's typically from repetitive needle access for those that have diabetes. So moving forward, altered pathology and morbidity. Again, as I said, those with RAA are typically asymptomatic, although those with symptoms, 90% of them will illustrate uncontrollable hypertension. That may also be marked with hematuria, unexplained flank pain, and of course, ballooning of the renal artery. Renal artery aneurysms are fairly rare disorder and has an incidence rate of around 1% of all recorded aneurysm cases. Ultimately, RAA affects only 0.1% of the entire population. However, those with RAA that suffer life-threatening hemorrhagic rupture have a suspected 80% chance of mortality. So frequent interval monitoring is recommended. Moving on, how do you diagnose a renal artery aneurysm? That's through renal angiography, but what is a renal artery angiogram? So renal artery angiogram is an imaging exam that is performed to view the arteries of the kidneys under fluoroscopy, a live X-ray video. Under localized anesthesia, this procedure advances a catheter through the femoral artery towards the bifurcation of the renal arteries within the abdominal aorta. The radiologist will inject iodine-based contrast dye through the catheter at points where the renal artery aneurysm is suspected, and the contrast dye then highlights the portions of the renal artery under fluoroscopy and is recorded to make an accurate diagnosis regarding the localization, type, and severity of the renal aneurysm. Indications of renal aneurysm, as we discussed, is uncontrollable hypertension, if not no symptom, hematuria, unexplained flank pain, and of course, ballooning of the renal artery. Contraindications to the renal angiogram. This is where proper patient interview comes into play. So the main contraindication for female patients is going to be pregnancy, particularly within the first trimester of conception, while other indications include an allergy to iodinated contrast dye, the necessary ingredient to visualize the renal artery. Similarly, a history of kidney failure or impaired kidney function with an eGFR rate of less than 30 milliliters per minute will contraindicate the patient from properly filtering the contrast media. Patient preparation includes a signed informed consent document to ensure that proper consultation for the risks, the pros, the cons, and complications of the exam with the physician has occurred. They're also asked to fast from foods and liquids for 8 hours prior to the exam, obtaining specific patient history such as medications they are currently taking and asking them to stop taking anticoagulants 2 days prior to the exam, and inquiring about history of bleeding disorder allows for a thorough patient assessment prior to the exam. A blood test may be ordered to test the clotting factors along with kidney function of the patient. Ensuring that female patients are not pregnant and inquiring if all patients are allergic to iodinated contrast dye, specific medicines, latex, tape, or anesthesia is necessary prior to the exam. Before beginning the exam, the patient will then be asked to empty the bladder and rectum as necessary. So major equipment list. This is a very specific list, but let's go ahead and go through it. An 18 gauge vascular access needle, 0.018 inch stiff guide wire, a 7F RDC guiding multi-hole catheter, introducer sheath, 20 to 40 milliliters of non-ionic iodinated contrast media, 10 milliliters of 2% lidocaine, a 10 and 50 milliliter syringe with the appropriate tubing, antiseptic, the fluoroscopic C-arm, and imaging monitors with their appropriate cables, and wound dressing and compression devices. So to perform the procedure, it's known as the Seldinger technique. It's very commonly used technique during interventional radiology. To ensure that all anatomy is properly visualized, the patient will remove the clothing, jewelry, and be asked to don a hospital gown. They'll empty their bladder and rectum before the exam and lay supine on the table. A licensed staff member will insert an IV to administer fluids within the arm and the leg, and then they'll be hooked up to an EKG monitor to follow their heart rate, blood pressure, their breathing rate, and O2 saturation during the angiography exam. The nurse will shave the area of the thigh, disinfect it, and then inject local anesthesia to numb the nearby area. Using a femoral artery, palpating the femoral artery, the radiologist will insert a vascular needle into the artery for access during the exam. The radiologist will then insert a catheter accompanied with the guide wire into the access site. Once the catheter has been successfully inserted, the vascular access needle is removed, leaving the catheter and guide wire within the artery. During the time, the catheter is monitored during fluoroscopy, and the catheter is maneuvered up the abdominal aorta until it is near the arteries, the femoral arteries. So performing the procedure, advancing the catheter and the guide wire up to the renal artery bifurcation through the abdominal aorta, and it's monitored under fluoroscopy. The radiologist will then inject a small amount of the dye to determine the area of the catheter within the renal artery to make sure it is in the correct place. Once it is in the correct place, the radiologist will inject more of the contrast media to fully visualize the renal artery branch. Again, the patient may feel nausea, passing headache, flushing sensation, or a salty or metallic taste, which is normal and should pass quickly. So once the radiologist has determined enough information has been gathered, the catheter and access sheath will be removed, and a member of the surgical team will apply pressure to the access site to minimize bleeding. Then dressing will be applied to the access site along with a mechanical compress, which will be applied to stop the bleeding, prevent hematomas, and prevent infection. So we talked about it briefly, but let's go more into depth. The contrast media that is used requires 20 to 40 milliliters of non-ionic iodinated contrast media, which is then injected at a rate of 10 to 20 milliliters per second per the radiologist's preference. And if there are multiple aneurysms or multiple areas of interest, you may need more contrast per the radiologist's recommendation. The filming protocol utilized is the C-arm intensifier is placed midway between the vertebra and the lateral skin border. And the IR will then enter at the level of the second lumbar vertebrae for the right kidney and the level of the first lumbar vertebrae for the left kidney. So post-procedural care, it's pretty simple. They are then, after the exam, brought to the PACU for several hours, and a nurse is then monitors their vital signs and their access site for bleeding or any abnormal changes. The affected leg should be kept straight for 12 hours, and they will lie supine for several hours in the PACU while they recover. They will then be encouraged to drink water and clear fluids to flush out the contrast dye out of their system. And once they are ready to be discharged, someone other than the patient must be ready to drive them home. It is actually recommended that the patient not drive for 24 hours post-exam. Once discharged, there's no restriction to the patient's diet or exercise unless informed by the physician, and they should just simply avoid strenuous exercise on the affected leg. Follow-up care at home includes monitoring the access site for excessive bleeding or changes to the leg, such as numbness, tingling, pain, change in color, or loss of motion. Continuing to drink plenty of fluids to flush out the contrast dye from the circulation is recommended, and it is advised to not undergo excessive strenuous activity or take a hot bath or shower to prevent damage or excessive bleeding at the access site. The patient may then resume anticoagulant medication routines 24 hours post-exam. Possible complications that may be associated with any percutaneous transarterial catheterization include the following, such as internal hemorrhage, local nerve damage, embolization, hematoma, post-surgical infection, temporary kidney failure, and damage to the arteries. So there was a lot of information, and there is a slight quiz right now. So the first question reads as follows. Where is the most common site for renal artery aneurysms to occur? Moving on, what is the most common type of renal aneurysm? Moving on, what is the primary symptom of those with presence of renal aneurysm? Moving on, what is the average volume of iodinated contrast media used during renal angiography? And lastly, what is the central ray centering point when imaging the right kidney? Okay, great. That was a lot of information. I hope you learned something, and on to the next person. Thank you.